Good morning. This is Gary Greenswag. Thanks for joining us. We have an interesting 45 minutes in store for you this morning. It is a special day, which is why some of us are in red attire, and Dr. Sagar is going to spend a minute talking about that.
Gary. Good morning, everyone. It is lovely to have you. So today is Go Red for Women Day. It's February 3rd, and really wanted to bring the reason that we're all together. So first, it is celebrate National Women Physicians Day, and a big gratitude from all of us here to the women physicians who have worked and dedicated their time, their thoughtfulness, their generosity, and their kindness to take care of our patients and also to be leaders for their teams. So we appreciate you tremendously. We hope that you take a moment to reflect on your awesomeness today, because you are awesome. So we wish you a fabulous day ahead. And also, no surprise, it is also Go Red for Women Day. So we want to wear National Red Day. We want to wear red, as you can all see, myself, Dr. Bond, Dr. Greenswag, and I'm sure many of you are wearing red, because we want to bring awareness to the risk of cardiovascular disease and the toll cardiovascular disease takes on women. Quick fact that I want you to remember going through your day and moving forward is it is the number one cause. So cardiovascular disease is the number one cause of death in women. And if you think about all the causes of death for all the women across the US, 1 in 3 deaths are attributed to cardiovascular disease. So it's a very important topic. It is something we want to improve on because it is preventable in many ways, and we can definitely decrease mortality and morbidity. With that, I will hand it back to Dr. Greenswag to introduce our speakers.
Great, perfect. Thank you. So we have Dr. Shields and Dr. Rachel Bond. And Dr. Shields is from Central California, I guess would be correct, right, Larry? And Dr. Bond's from Phoenix. So let's talk about Larry first. He is a maternal fetal medicine specialist, practices in Central California. He is the physician vice president for the Women and Infant Clinical Institute. Can I say Clinical Institute / service line, or just Clinical Institute for Common Spirit Health? So he leads kind of all of our efforts in the hospital and out of the hospital in terms of women and infants. He completed medical school and residency training at the University of Texas Health Sciences in San Antonio, and his fellowship in maternal fetal medicine at the University of California in San Diego. For the last 15 years, he's focused on reducing maternal mortality related to maternal hemorrhage, hypertensive disorders of pregnancy, and the response to abnormal maternal vital signs, and the development of a maternal early warning trigger called MUTE. And then let's talk for a minute about Rachel. Dr. Bond is an attending cardiologist in Phoenix, Arizona. She's devoted her care to the treatment of heart disease through early detection, education, and prevention. She is a women's heart health and prevention specialist and the author of several review papers referencing maternal health, sex and gender differences, and cardiovascular conditions that predominantly affect women, along with opinion pieces at addressing health equity, reducing health disparities, and promoting professional development of women and minorities in the health sciences professions. She is a fellow in the American College of Cardiology. She is a member of the American Society for Preventive Cardiology, where she sits on the editorial board. And she is let's see here, co-chair of the Cardiovascular Disease in Women and Children's Committee at the American Association of Black Cardiologists. She is a national spokesman for the Go Red for Women campaign. So I want to know if our poster is all right. And recently received the coveted Nanette Wenger Award for her work and advocacy in women's heart health, along with being named one of the most influential women in Arizona in 2022. So with that, I think we're in for a great morning. I see some little stars floating across the screen. So Larry, I think we're going to start with you, Dr. Shields, and then we'll go to Rachel.
There. So I'm really here to really just tee up Dr. Bond's talk. And I thought the best title for this was really a window into the future of health risk in women and long-term health for women after pregnancy. And I wanted to really highlight a few things. If you look at the rate of two big risk factors for ongoing cardiovascular disease in the future. The first would be gestational diabetes. And as you can see from the two charts here, the rate of gestational diabetes has increased tremendously as we've gone. And then, as you can see from the bottom right there, the rate has gone up in all ethnic groups, particularly non-Hispanic Asians, but also American Indians, Hispanics, non-Hispanic whites. And the rate has really started accelerating, as we got from 2016 onward, almost to, a straight upward curve. The other major risk factor that we see is hypertensive disorders of pregnancy. And this graph goes back much further, but you can see that both hypertensive disorders of pregnancy, which is going to include preeclampsia, chronic hypertension, gestational hypertension, over this 20-year span that ends really in 2014, the rate has gone up 73%. If you look at just chronic hypertension, it's 250%. And then if you look more recently, almost 10% of pregnancies are complicated by some degree of hypertensive disorder of pregnancy. And depending on your race and age, this can go up to 20% if you have African-American race, and it goes up even higher if your age is over 35. And I think most people dealing with pregnant women realize that many women are now having either their first or subsequent pregnancies after the age of 35. So with that as a backdrop, I also wanted to highlight some changes that have occurred over the last, 20 plus years. When I was a resident, if you were treating someone for diabetes, you were happy if their fasting blood sugars were less than 110 and their postprandial blood sugars were less than 140. And if they skirted a little bit higher than that, you probably wouldn't start them on any medicine unless they were consistently above those values. And if you look at our values now, we want our fastings less than 90, our 1 hour postprandial is less than 130. So, huge change in the degree of tightness of control for diabetes during pregnancy. And then most recently, over the last 2 years, this same phenomenon has occurred with patients with chronic hypertension, where we used to be recommended not to initiate treatment until it was greater than 160 over 110 with a goal of 140 over 90. Now we treat if they're over 140 over 90, and the data that's going to be presented next week at our national meeting, Society of Maternal and Fetal Medicine, suggests that optimal outcomes in this population is for the control less than 130 over 80. And so really a huge change in how we're managing these two very common complications of pregnancy. So then I just wanted to kind of run through a case that's actually occurred at my institution. It was a 30-year-old, have her first baby. She was African-American. She had a BMI of 21 at her first prenatal visit, and the blood pressure was 120 over 70. She had an unremarkable course to 32 weeks when she didn't feel right and noticed her blood pressure at home was 175 over 109. This individual was a pharmacist at our hospital. Labs were normal. She came in, she received IV labetalol, and then was stabilized on PO labetalol due to gestational age at a blood pressure of about 140 over 85. The next morning, I walked into the room. She had an ice pack on her head and developed severe headache, which is one of the warning signs of preeclampsia, thought to be a precursor to eclampsia. She had a breech presentation, underwent a cesarean section, delivering a slightly small baby, and at her 2-week postpartum follow-up, her blood pressure had normalized. 4 years later, She has a BMI of 28 when she comes in for her second pregnancy. Blood pressure now is 130/78. She had been started on low dose aspirin, as that's a universal recommendation for a patient with her history at this point. She had an unremarkable pregnancy to 28 weeks when she tested positive on her 1-hour glucola. She had a normal 3-hour glucola, so she wasn't given a diagnosis of gestational diabetes at that time. And then, similar to her last pregnancy, although a little bit later in the pregnancy, she had a blood pressure 177/109, normal labs, underwent a repeat C-section, again had a small for gestational age infant. She had very labile blood pressures postpartum. She was being treated with maximum dose of labetalol, nifedipine, had been started on lisinopril, and due to the multiple medications, there was a cardiology consult requested. And at this juncture, I want to lead us directly into Dr. Bond's talk, because I think this is where she gets most of her work in the inpatient setting with obstetrical patients. So I'm going to stop sharing.
Yes, thank you so much, Dr. Shields. And as I pull up my slides, I think it's relevant for us just to acknowledge this particular case as we dissect my own presentation, because I do think we'll have opportunity, at least hopefully after, for questions and answers to see if during this particular case's journey, should cardiology have been called earlier? Should cardiology even have been seeing the patient in between her interconception period, meaning in between her pregnancies? So I am technically challenged, so hopefully you guys do see my screen. Okay, you do, perfect. So I will be talking today on the intersection of maternal health and cardiovascular disease in the continuum of care. Thank you again for the opportunity to talk today. As noted, I have no relevant financial disclosures. My hope is that by the end of this presentation, you will be able to have at least 3 key findings when you leave the presentation today. Number 1, you'll have a better understanding of the intersection of maternal health and cardiovascular disease, as well as what the impact social determinants of health play across the maternal health continuum. Number 2, you'll learn how to adapt strategies and promote solutions to improve maternal health morbidity as well as mortality, especially in the greatest risk populations. And then the last is understand the important role cardio-obstetrics or maternal heart teams play in improving outcomes across the care continuum. One way that my hope is to highlight that is to really talk a lot about the work that we're doing here locally in Arizona. As Dr. Segar mentioned, today is National Wear Red Day, and I did want to really highlight the historical context of this. So this was initially created back in the year 2000, initially by the NHLBI. They handed it over to the American Heart Association after they implemented their Go Red for Women campaign. And on the first Friday of February, everyone across the country dons the color red. And the goal is to raise awareness and spread awareness, more importantly, in the hopes to help eradicate cardiovascular disease in the millions of women all over the nation that it does impact. We know that, as Dr. Segar mentioned, heart disease causes about 1 in 3 women's death each year. And I always like to begin with this particular graphic because I do think a picture is worth 1,000 words. And as noted, heart disease is the greatest cause of death in the United States, but we do see that it actually is an equal opportunity killer. Back in the mid-1980s, or really before the mid-1980s, men in blue, women in red in this graph were dying at much higher rates of cardiovascular disease. Once the mid-1980s happened, we began to see a trend downwards in the number of deaths in men. The reason being is that this is where we had the introduction of lipid-lowering therapy like statins. This is where we had the introduction of angioplasty. And what we began to note with the decline in men and the increasing trend in women dying was that men were disproportionately being provided those therapies and women were not. It really wasn't until the year 2000 where, as noted, the Go Red for Women campaign began to take effect, that people began to highlight the fact that heart disease is actually killing women, if not the same, actually at higher rates when it comes to a very preventable condition. So the American Heart Association created the Go Red for Women campaign to raise awareness to the community, but they also joined forces with the American College of Cardiology to create guidance as well as guidelines on how to best treat women. As such, we began to see a steady decline in the number of deaths, again, similarly in men, but most notably in women. But if we begin to look at later years, we're seeing that the trends, unfortunately, are going in the wrong direction. And when we separate these trends, most notably by sex as well as age, we see that deaths continue to decline over the past several decades in those greater than 65 years of age. Improvement in deaths, however, are still slow among those less than 55, especially in women, particularly between the ages of 25 to 54, where in this graph, very nicely, you can see a flat line. And it's important for us to conceptually understand the scope of the problem of why more and more women are dying at younger and younger ages from cardiovascular disease. It's not a simple answer, but my hope is that this very busy slide will dissect you through it. Well, when we know about cardiovascular mortality, we know that CAD, coronary artery disease, or myocardial infarctions, they do account for the majority of cardiovascular deaths in women, and most notably in-hospital mortality rates are greater in women than men. When we think about in-hospital mortality after childbirth, cardiovascular disease is the leading cause of hospitalizations for women, but we see that there is a significant increase in the number of women who present with acute myocardial infarction and unfortunately never leave the hospital. We see this more commonly in women between the ages of 35 to 54. If they're female, if they have higher comorbidities, such as those chronic modifiable risk factors, which I'll be getting into, but also we see this more commonly in Black women. And we'll be highlighting a lot of those disparities from a race and ethnic perspective as I move along in this lecture. But one reason we're seeing these higher in-hospital mortalities is because women are less likely to undergo or be provided invasive strategies for mechanical reperfusion, such as coronary angioplasty and stent placement. They're also unlikely to be provided guideline-directed medical therapy when presenting to the hospital, including a baby aspirin, possibly leaving on the higher intensity dose of a cholesterol medication like a statin to lower their likelihood of having poor outcomes. And then post-discharge, when they leave the hospital, similarly, they're less likely to actually go home on the recommended medications and even be referred to cardiac rehab, which we know leads to a notable improvement in mortality when women in particularly go not only to rehab, but actually complete the entirety of the 36 sessions of rehab. Because of this, women have a higher likelihood of having increased rehospitalizations. And it's not just for cardiovascular disease. We also see these disparities when it comes to heart failure. Women less likely to be referred for left ventricular assist devices if they have advanced heart failure. We see this for atrial fibrillation, which is a very common arrhythmia where women are less likely referred to electrical doctors or electrophysiologists to consider even the possibility of atrial fibrillations. We see this with peripheral arterial disease. When women presenting later on in the course, therefore having much more likelihood of having critical limb ischemia with the possibility of needing amputations. We also see this with valvular heart disease. So disparities across the board when it comes to cardiovascular disease are noted when it comes to sex and gender. We know that a lot of the reasons why we're also seeing a higher rate of cardiovascular disease, poor outcomes in women is because awareness is just not there. The American Heart Association had released a trial, or a very brief study, I should say, back in 2019, where they saw that 44% of women were aware that cardiac disease is their leading cause of death. In 2019, this was down, unfortunately, from 65% in 2009. And when they honed in on the group that specifically had the lowest rates, it was young women between the ages of 25 to 34 who identified as either Hispanic or Black. We also know that when it comes to women in general, they do sometimes, when presenting with signs or symptoms of coronary artery disease, may have concerns for presenting with atypical symptoms, where their symptoms may not necessarily include chest pain. It may include more shortness of breath, more shoulder pain, possibly even fatigue. As such, even us as clinicians may not necessarily think of cardiovascular disease, and that's where we're seeing a lot of these disparities as well. And we also know that when it comes to research, we're not doing as good a job in representing more women, or even not more women, equal numbers of women and men. Because when we think about larger cardiovascular trials like CAD or heart failure, at a minimum, we're seeing about 20%, but at a maximum, 30% of females that are being enrolled. So there's a lot of disparities if we're not actually investigating the underlying pathophysiology of the same population, which really and preferably should be both equal to both men and women. And I brought up the intersection of race and ethnicity because we do know that not only are there sex disparities, but when it comes to cardiovascular disease, underrepresented minorities, those coming from ethnic and racial minorities are having the highest rates of cardiovascular disease. And this includes people that are of Afro-Caribbean descent, Latin, as well as South Asian descent with the highest rates of cardiovascular disease. I live in Arizona, also tend to take care of a large group of indigenous population. And we know that they also have subsequently high rates, including social, economic, and political challenges that are really the onus of why we're seeing those rates. But even from a geographical location, we know that women living in more rural and remote areas experience cardiovascular disease, morbidity, and mortality much greater. And then, of course, there's socioeconomic status, which those that have a lower socioeconomic demographic are more prone to increased rates of cardiovascular disease. But it's important to highlight that the greatest risk at this moment in time are in Black women. Black women are having greater than 1 in every 2 Black women have some form of cardiovascular disease, and that's above the age of 20. So many of these women possibly deciding to have children. Why this is important is because this does actually translate into what we're seeing with the maternal mortality, morbidity crisis as well. And one thing that it's important to acknowledge is, while we know that the greatest driver of health is beyond the scope of healthcare alone, the greatest driver is the social determinants of health. It actually impacts nearly 80% of our health. So this is where people are born, where they grow up, where they live, and where they play and pray. And we know that it does contribute to the cardiovascular health outcomes in women, especially women of color. I was privileged to have the opportunity to provide an opinion piece in circulation last year for actually Go Red Day with Dr. Michelle Albert, who's the current president of the American Heart Association. And in that piece, we wanted to understand the biology of why we're seeing these highest rates in Black women. And one thing that we thought of was the fact that there is some phenomenon called the superwoman schema, where the historical stereotyping, oppression, disappointment, mistreatment, spiritual values, as well as foremother influences, that takes a toll on our sympathetic nervous system, the inflammatory system, the hypothalamic pituitary axis, all increasing allostatic load and leading to premature cognitive and cardiovascular disease. And we know that these disparities, as I already noted, translate into what we're seeing and why we're seeing the poor maternal morbidity and mortality outcomes. These outcomes, it's important to highlight, can occur up to 1 year after delivery. In fact, the CDC just released that 53% of mortalities when it comes to pregnancy occur 7 days to 365 days after a mother has delivered. And we know that cardiovascular disease remains to be the leading cause of maternal death, particularly in Black women, largely driven by peripartum cardiomyopathy, which represents about 45% of all pregnancy-related death between 6 weeks and a year postpartum. Thereafter being hypertensive disorders of pregnancy, which actually do impact one's risk of having peripartum cardiomyopathy, as well as stroke. And why this is key is because pregnancy is nature's cardiac stress test. We know that, we've heard it, but it's actually glaring to see the statistics that lead to that. And I think similarly, another picture that is worth 1,000 words is seeing the disparities that when it comes to Black women in the United States. So here we see deaths per 100,000 live births, US compared to other high income countries. And we can see that as it stands, the United States has the highest rates in general, but then when you actually delve deeper into it from a race and ethnic perspective, we see that Black women are dying at a 3-time greater rate than white women. And it's not just necessarily mortality that we should be talking about. We should be talking more so probably about the morbidities, because for every maternal death, there are about 75 to 100 more women who suffer a life-threatening maternal near miss. So this is the greatest percentage that we can see in Black women, who are about 2 times as likely as non-Hispanic white mothers to experience these severe maternal morbidities. And it's important that we acknowledge that this is even when adjusting for sociodemographic factors. So even if we have an affluent Black mother who is a graduate, she is more likely to have a poor outcome, both morbidity and mortality, as compared to a white female who may not have even received a high school education, as an example. And this then disentangles, I would say, the driver, which another publication that I was honored to be a part of really stems into what we're seeing and the impact that a lot of these disparities, including racism, can play on the Black maternal health crisis, where we see that the structural and institutional racism may lead to conscious and unconscious interpersonal racism, which impacts social determinants of health negatively. That is what really is driving the healthcare inequities and the health inequities. And this is severely burdening a lot of our Black mothers, a lot of our Black women. And then encompassing that superwoman schema that I mentioned, which is just that extra inflammation, that extra stress hormones that are leading to the premature cognitive as well as cardiovascular disease. It really comes as no surprise that we're seeing that these disparities are impacting women, particularly Black women, across their entire lifespan, but most notably during their pregnancy. And I think as we acknowledge more and more that stress and chronic stress and a lot of the lived experiences can impact one's own cardiovascular risk, it's also important that we acknowledge how that in of itself can actually lead to a higher risk of modifiable risk factors. Particularly, we know that when we optimize these modifiable risk factors that may impact reproductive health, it's actually a way for us to lower the likelihood of having these poor outcomes. But it's also important that we highlight the fact that a lot of these risk factors can lead to adverse pregnancy outcomes that occur during pregnancy, and how those adverse pregnancy outcomes can actually be risk factors in the future for cardiovascular disease. So when we think about the thing that makes cardiovascular disease largely preventable, 80% of the time we could prevent heart disease, it's those traditional modifiable risk factors, the diabetes, the smoking, the obesity, the physical inactivity, the hypertension, and the dyslipidemia. And we know that the prevalence of obesity, hypertension, and diabetes is the highest, unfortunately, among Black women above the age of 20. And we see that this is increasing the prevalence pre-conception. Now, this would then give us an opportunity to say, well, let's optimize those risk factors before somebody decides to have a child. That is what we are aiming to do. But the fact of the matter is that 45% of pregnancies in the United States are unintended. So preconception counseling is scarce. And this is why it's important that at any point in time when somebody is entering our healthcare system, we're reinforcing the importance of, at least at a minimum, getting these numbers tracked and really providing them with the information on how to best manage them. And we bring up also, when it comes to women's cardiovascular health, as I noted, a lot of the risk factors that can occur, or a lot of the conditions that could occur during pregnancy, and how those do translate to future risk factors for cardiovascular disease. These are umbrellaed under a term called adverse pregnancy outcomes. That includes, as Dr. Shields noted, the hypertensive disorders of pregnancy, the gestational diabetes. We know that having preterm delivery, having an infant small for gestational age, or even placental abruption, those are adverse pregnancy outcomes that do affect about 20% of United States pregnancies annually, but they can lead to future cardiovascular disease up to even 20 years after delivery. Preeclampsia in particular is the leading cause of severe maternal morbidity, and we, as I already noted, see significant health disparities from race and ethnic perspective. And as I highlighted, the risks of these adverse pregnancy outcomes can be up to 20 years post-event, but let's talk about the actual evidence when it comes to the risk. For gestational diabetes, as an example, it could actually increase one's risk to basically transition to full diabetes by greater than seven times that of somebody who did not have gestational diabetes. The same could be said for hypertensive disorders of pregnancy, 2-time greater risk of developing diabetes in the future, 4-time greater risk of developing hypertension in the future. And when it comes to preeclampsia, we're at a 2-time greater risk of dying from cardiovascular disease. And this risk is greater for mothers who have had recurrent episodes of preeclampsia or preterm preeclampsia. So it's extremely important that as we're taking a history, a medical history, that we're asking if there were any complications during the pregnancy, and more notably, taking a detailed pregnancy history. Preterm labor, similarly, we see that so that's basically defined as women who deliver before 37 weeks gestation. Preterm delivery has had the highest rates of both simple and complex cardiovascular events, as well as higher rates of total cardiovascular related hospitalizations. And we know that even having very preterm first birth, so before the age of 32 weeks gestation, that can double the risk of having a cardiovascular event in the future. So as noted, it's extremely important that us as clinicians are asking the question, what happened during the pregnancy? Did you have any of these particular adverse pregnancy outcomes, especially if you are a cardiologist, because the likelihood is the answer is yes. Now that we know that more and more women are having children later on in life, but most notably, this can also dictate how aggressive we should be in screening them for any future cardiovascular events. And that then poses the question, well, what should the approach be now that we know that what happens during pregnancy actually is a window into one's future health? How should we be screening these particular moms? Should we actually be screening them? And I think that it also highlights the role that all of us in the healthcare system plays, starting with pediatricians to optimize health before one may decide to begin a family, including primary care clinicians, obstetricians, cardiologists, and how possibly utilizing this through a more unique cardio-obstetrics team can actually lead to improved outcomes. And I do want to highlight the importance of a pregnancy heart team. So the best way to define a pregnancy heart team is a team that is led by clinicians from cardiology, MFM, obstetrics anesthesia, pharmacy, and nursing that support a more holistic approach to patient care while also facilitating opportunities for cross-disciplinary education. Many a times, the pregnancy heart team doesn't actually get involved until the particular patient is pregnant, and we know that there is some limitations because of that, because as noted, a lot of the times, if we optimize health even before pregnancy, we can lower the likelihood of having poor outcomes. But also, as noted, a lot of the actual complications are occurring after pregnancy. So the goal is to really have a pregnancy heart team that's across the entire maternal health continuum. But as it stands right now, the more traditional pregnancy heart teams have been involved for mothers that may have had either pre-existing congenital or acquired cardiovascular disease, all of which are listed there, including valvular dysfunction, pulmonary hypertension, cardiomyopathy, CAD, disease of the aorta, arrhythmias, or venous thromboembolism, or even for moms that have pre-existing risk factors like, as noted, the hypertension, the obesity, the dyslipidemia, or the insulin resistance that may predispose them to those adverse pregnancy outcomes that we've already delved into. But as I said, the perfect sort of pregnancy heart team would be one that's not just necessarily involved in the care of the patient during the pregnancy, but that entire maternal health continuum. As such, we here in the Arizona market at Dignity Health decided to create a maternal heart council that does just that. The mission of the council is to provide specialized care for women with a pre-existing cardiovascular condition or those at high risk for cardiovascular complications during and or after their pregnancy. The vision was really to create regionalization, common pathways, policy creation, education, with the goal to reduce these preventable, right, largely preventable morbidities and mortalities. One thing I didn't address is that a lot of these mortalities, just like cardiovascular disease, are 80% preventable. And we know that disparities in care exist at all areas of the maternal health continuum, but most notably making sure that this council is involved in that critical first year of postpartum and beyond. And I wanted to delve deeper into what each section of that council encompasses, because the goal is, again, to view pregnancy as a window to future health, where we have the actual patient in the center of this maternal health continuum. And at each stage of the continuum, expressing the importance of what we in our own institution are doing to ensure that we lead to improved outcomes from both morbidity and mortality perspective. So we know that California has done a phenomenal job in lowering the rate of maternal mortality. They did this through the California Maternal Quality Care Collaborative, which is a quality improvement toolkit that is focused on decreased rates of not just necessarily hypertensive disorders of pregnancy like preeclampsia, but they also have largely done this through hemorrhaging during pregnancy as well. And this has been since 2006 because of this initiative where they create algorithms that are very much so hospital-based, and more importantly, at an acute setting where the mother may be presenting to the hospital, such as the emergency department or labor and delivery, presenting with acute symptoms. They've created algorithms to give guidance on how we should go about screening ththese patients, potentially checking beta natriuretic peptides on these mothers that are coming in with shortness of breath, checking cardiac biomarkers, checking electrocardiograms, and considering getting cardiology into the actual discussion much earlier on in the patient's antepartum course. Now, I do think it's important to acknowledge that despite the fact that because of this initiative, California has decreased their maternal mortality rates by about 65%, Black and Indigenous women still experience 3 to 6 times the rate of maternal mortality. And this highlights the fact that a lot of the work that has been focused on, at least with this particular quality care collaborative, is during that antepartum period. And one thing that we in our institution have noted is that a lot of these algorithms should still be up to that critical 1 year post-delivery. So as such, we have been educating our emergency providers to ask the question, when was your last pregnancy? Because if the pregnancy was within that year, it's very possible that the presentation is as a result of a complication of that particular pregnancy. But beyond that, the other disparity or what we're noticing, or what I should say, a discrepancy that we're noticing with the California Maternal Quality Care Collaborative and collaboratives like it, is that it's very centric to hospital settings. We know that in order for us to manage the disparities in care, we also have to improve the care outside of the hospital, because this is where we're first meeting these particular mothers, hopefully, in the ambulatory care setting, where we have that opportunity to provide education and hopefully screen for signs and symptoms of some of these adverse pregnancy outcomes. So as such, in the antepartum ambulatory care setting, we've created a personal passport to heart health, which is a phenomenal tool that we provide our mothers. And I definitely, whenever I have a mother that comes in through my clinic, they leave with this very great tool that goes over the signs and symptoms of heart disease before, during, and after pregnancy. It highlights a lot of the common signs of preeclampsia as an example. It gives them an understanding of if they are at a higher risk, just based on the general understanding of who is at a heightened risk. It also talks to them about the importance of tracking their numbers. And we work with them on getting access to an ambulatory blood pressure machine. And I think it goes a long way, because it at least begins the conversation about the risks that we are seeing, and more importantly, how to optimize those risks. Another thing that's extremely important during this antepartum phase is that if we have somebody who we think is at a heightened risk of adverse pregnancy outcomes, in particular preeclampsia, this is where we're really counseling them on the importance of maintaining exercise. We know that a lot of data shows that a moderate amount of exercise, including briskly walking, can actually lower one's risk of having preeclampsia by almost 40%. We also talk about the importance of the initiation of low-dose aspirin. We know that a lot of data shows that anywhere between 12 to 28 weeks gestation, the initiation of low-dose aspirin could actually reduce preterm preeclampsia by 60%, preferably starting before 16 weeks gestation. We also talk about a well-balanced diet. And now, because we know that there are many disparities when it comes from a race and ethnic perspective, we're actually looking specifically for Black women who have the highest rates. Should we be offering them a different approach? And one thing that what most recently has been shown is that the use of the Mediterranean diet during actual pregnancy can lower one's risk of preeclampsia, particularly in the Black community. Dr. Shields touched upon a lot of the recommendations in terms of us being more aggressive in managing women's blood pressure during their antepartum period, particularly if they're coming into the pregnancy with a known history of chronic hypertension. This was the chronic hypertension and pregnancy trial that was released back in April of last year at the American College of Cardiology, which was so exciting for us in the cardio-obstetrics world, because it actually answered the question that we should be lowering the threshold of when we treat high blood pressure, especially in mothers that have chronic hypertension, initiating treatment if their blood pressures are greater than 140/90, and no longer waiting until they have that severe range blood pressure, which tends to be 160/110. So because of this, and this is one thing that we emphasize within our own council, we really want to provide that education that we're targeting these mothers because we know it's going to lead to improved cardiovascular outcomes. When it comes to preconception and postpartum, I made note already of the fact that 46% of pregnancies were unintended, but when it comes to postpartum follow-up, we know that less than 40% of women actually make it to their first obstetrician visit. And that unfortunately is worse in the more disenfranchised populations. And we know that one way for us to improve cardiovascular outcomes in the future is to make sure that we're ensuring both before pregnancy, but most notably after pregnancy, we're optimizing any of their risk factors, not only screening them, but optimizing them. One thing that we're extremely fortunate to be having the opportunity to do here at Dignity Health in Arizona is partner with the American Heart Association and the American Medical Association through a grant for a particular program called Target Blood Pressure. So what Target Blood Pressure does is it provides education. So the clinic is aware of the best practice on how to actually check one's blood pressure. But not just that, it also provides the patients with information on how to do that as well. But also it goes over the ability to actually lower one's rate of having any issues with their blood pressure through highlighting the American Heart Association's Life's Essential 8, which talks about checking your numbers, getting your blood pressure checked, getting your cholesterol checked, getting your blood sugar checked, making sure your weight is stable, that you're exercising at least 150 minutes per week of some form of cardio, and you're having a well-balanced, heart-healthy diet. And the last step being sleep. We know that's easier said than done with some of these new mothers, but it is recommended that we're maintaining at least 6 to 8 hours of sleep a night. Less than 6, more than 8 actually can increase one's risk for cardiovascular disease. So we're extremely excited that we're going to be joining forces with the American Heart Association through the Target Blood Pressure campaign, but more importantly, optimizing the health of these moms after delivery as well as before they decide to have children. I do think it's important to also address interconception, which is in between pregnancy, because this is an opportunity where we really need to be emphasizing the importance of having ongoing medical care, especially if these mothers have had adverse pregnancy outcomes. When we think about even in between pregnancies, we know that excessive gestational weight gain and postpartum weight retention can actually increase one's risk of having gestational diabetes, as well as hypertensive disorders of pregnancy for future pregnancies. So the goal really needs to be to maintain a healthy weight during pregnancy, but most notably to return to pre-baby weight within the first 3 to 12 months postpartum to lower the chances of this happening. And one thing that we are highlighting within our own health institution is what the American Heart Association and the American College of Obstetrics and Gynecology have been preaching really since the outskirt of this sort of cardio-obstetrics initiative. This was back in 2018, where both actual national societies joined forces to create a presidential advisory to express the importance of promoting risk identification and reduction of cardiovascular disease in women through collaboration with obstetricians and gynecologists. And why this is important is because looking at this very busy diagram, we see that we all begin with normal arteries and vascular function. And it's a matter of what we actually get exposed to that can increase our risk of having this normal artery eventually lead to this plaque burden where we have either microvascular dysfunction, eventually leading to subclinical atherosclerosis, or unfortunately then leading to obstructive CAD. And included in these risk factors, hypertension, obesity, hyperlipidemia, the more traditional, also are the adverse pregnancy outcomes, which I've already given you the statistics in terms of the greatest risk for both high blood pressure and cardiovascular disease. But it's important that we're actually acknowledging the fact that these adverse pregnancy outcomes are risk factors, because we want to highlight the ability to keep that vessel looking as normal as that and preventing it from progressing to that obstructive CAD. So then the next question is, well, how should we be doing that? We know number one is that we should be personalizing patient care and making sure that there is collaborative care. Risk stratification obviously enables early identification of targeted care towards prevention, but currently there are no risk calculators that incorporate pregnancy complications, something that the American Heart Association is working on to change. What I will say is that the American College of Cardiology and the American Heart Association guidelines do suggest that we include these adverse pregnancy outcomes as risk enhancers, which I'll be delving into. So when we think about what are the steps to success to reduce cardiovascular disease in women, the most easy step is actually screening for these sex-specific risk factors, including all of those adverse pregnancy outcomes that I mentioned. Step 2 is if these sex-specific risk factors are present, we then assess for traditional risk factors. We talk to the patient in step 3, about how we actually can lower how we could aggressively manage these risk factors, as already noted through life's essential aid or other measures that can really hone in on the preventable way to lower these modifiable risk factors. And then step 4, we think about estimating the risk and treat accordingly with considerations that are sex specific. Right now, as it stands in the cardiology world, as well as the primary care world, we are encouraging everybody to assess one's 10-year atherosclerotic cardiovascular disease burden. And in order for us to do that, it's important that we address the limitations that may be there. So when it comes to the standard American College of Cardiology and the American Heart Association prevention guidelines, one thing that we know, and this is particular to patients that don't have diabetes or severe hyperlipidemia, is that there are some limitations because many a times it's not black and white. We may fall into a spectrum where the patient is deemed lower risk just because the risk equation doesn't include the adverse pregnancy outcomes. And in that situation, the utilization of calcium scoring has been recommended, but it's more clear if those patients fall in the borderline or intermediate risk, where we may say there could be benefit in starting them on medications to lower their cholesterol using lipid lowering therapy, but the patient either remains on the fence or the clinician remains on the fence because there's not clear enough information that their risk is high enough to initiate that. Now, what we are trying to do when it comes to cardiovascular disease is knowing how preeclampsia is a sex-specific cardiovascular risk enhancer. Should we actually be offering some of these mothers calcium scores to see, do we already see evidence of subclinical coronary atherosclerosis? Knowing that preeclampsia is an independent risk factor for early onset of coronary artery calcium in younger women, one trial actually saw that these women can be 4 times as likely to have coronary artery calcium compared to women between the ages of 40 to 45. So does this mean that we should be doing calcium scores on all moms who have had preeclampsia? The answer is probably no, but it does pose the question, how do we best risk stratify these women with adverse pregnancy outcomes? And then that brings us to the importance of research. In order for us to figure out how best to manage these women, we actually have to first figure out what is the best way for us to identify these conditions and then treat them. And a lot of that comes through research. So in conclusion, it's important for us to acknowledge that more American women die from heart disease than any other cause, but the disease exacts actually a bigger toll on Black American women, where 60% have some form of cardiovascular disease. Maternal mortality and severe morbidity is steadily rising in the United States over the last several decades. And this is, we know, cardiovascular disease, the leading cause of death that disproportionately impacts Black women. But the greatest driver of health are actually because of the social determinants of health, which have been driving these psychosocial stressors. And the good news is that women who can reduce their risk for cardiovascular disease and maternal mortality, they can do it by up to 80% through various lifestyle factors and through collaboration through these cardio-obstetrics and maternal heart teams. And as I already noted, more research is absolutely necessary. And one last thing I did want to highlight is that a lot of this work is already being done by key stakeholders, including the American College of Cardiology, the American Heart Association, the Association of Black Cardiologists, which I'm very fortunate to volunteer a lot of my work with. And I've been actually working with all of these organizations to really highlight the importance on education and that we're following these mothers across the care continuum. And I just wanted to acknowledge within my own opportunity at Common Spirit Health, we are working on also the impact of what our own institution can have nationally with Common Spirit Health taking care of 1 in 40 pregnancies, we possibly can take the model of what we're doing here in Arizona and see and actually replicate it in other areas across common spirit, because the goal is for us to lower the likelihood of cardiovascular outcomes, both morbidity as well as mortality. So with that, I did want to also acknowledge Women's Physicians Day, and I look forward to any questions that the audience has. Thank you.
Great. Thank you. Terrific. No other comments. It was terrific. But let's go, Dr. Sagar.
Yes. So we're going to open up our panel for questions. And, you've shared such a phenomenal array of reasons that it's important that we use the time and the advocacy and our clinical expertise effectively to really change this paradigm. I know there's a few questions from the audience, so I would love to start there. And then while people are still thinking, please give us more questions you would like to ask. So one question is, can you talk a little bit more about the greater incidence of cardiovascular disease among women, especially young women, and those who identify as persons of color? I'm thinking about those who identify African Americans or Hispanic, and their atypical presentation of cardiovascular disease. Could it be attributed to social determinants of health or the burden of mental health due to social determinants of health, such as anxiety?
Absolutely. So one thing that's relevant for us to acknowledge is that, as I noted, 80% of our health is dictated by those social determinants of health. A large driver are the psychosocial stressors that many of these communities of color experience. We know that, as I hopefully nicely demonstrated to you, that does increase allostatic load, which impacts the sympathetic nervous system, the hypothalamic pituitary system, as well as just all of our stress hormones and inflammation, and all of that is leading to premature cardiovascular disease. As such, it's important that we are actually screening those particular communities for chronic stress, anxiety, depression. One thing that I did hone upon is that regardless of if we come from those communities or not, anxiety, stress, depression, those are actual risk factors independent for cardiovascular disease, and they do disproportionately affect more women than men. So I would say that the greatest driver of why we're seeing these disparities in those particular communities 100% has to do with the psychosocial stress portion of it. And as such, it is important for us as clinicians to actually screen for that.
You're pulling my heartstrings when you say screening, because as a primary care internal medicine, I'm all about prevention. So thank you. And I think the next question is really to both you as well as Dr. Shields, is how do we make it much more easier, much more tangible for all of our OBs and all of our cardiologists across the system to really be a little bit more in tune for screening, but also having a threshold for treatment, perhaps a little lower than what we are currently practicing?
I think that we have to provide more education so people are aware, number one. And what we've done within the Women in Clinical Institute is really highlighted this in the acute care setting, where every patient, every time, every hospital, every patient, every time. And we need to move that motto to our outpatient setting. So every patient, every single time, gets the same treatment. And we are applying these new guidelines that suggest that much lower blood pressures are going to improve outcomes, and the same for our diabetes care. And Rachel probably can add some other areas as well, but from the obstetrics and MFM side, those are where we have our opportunity to really work and improve outcomes. I mean, there's long-term data showing that if you're in a organized diabetes program related to your pregnancy, even though diabetic moms that are pregnant have traditionally had worse outcomes, your outcomes are actually better than a low-risk population. So that it does work.
Dr. Bond, would you like to add?
Yeah, I was just going to add that we understand that the culture right now is not necessarily following along with what we believe we should be following along with. But one thing that we are trying to do to change that is actually revamp education, both nursing and medical school education. So right now, I will say, at least from a cardiovascular perspective, a lot of our national societies are working on restructuring, not just our cardiology fellowship, but starting as early as medical school to try to incorporate these sex disparities and highlight the social determinants of health, how those are the greatest risk factors. Because I think for us to change how we practice, it really should begin at the very beginning of when we start to practice. And I think all of us on this panel can probably attest to that. I know for sure I didn't necessarily learn a lot of the things that I now am deemed an expert in medical school. I kind of had to learn on my own as I had anecdotal data from patients and information and did my own teaching. But to that point, we don't want that to be a norm. We really want to make sure that we are revamping the education at both the medical school and nursing level.
Dr. Greenswag, would you like to add?
I have one question. This was great. Thank you so much. Social determinants aside, and not to in any way diminish the importance, is there any studies around genetic sequencing for these patients, mutations, things that may make them more prone to the social stress? Why do some people have these conditions and maybe other folks with the same social stressors may not? So I just wondered if there's any genetic link.
So we do know that our environment does impact our genetics, right? There's a whole area of epigenetics as well. So I will say that you bring up a very valid point that highlights the fact that more research is necessary. And one thing that I think is important with each research that we do is that we add that qualitative aspect to it to actually hear the patient's lived experiences and their voices, because that does impact the outcomes. We see this with all of our cardiovascular trials, probably obstetrics trials as well. But I do think that it's important that we address the fact that where we grow up and the environment that we are a part of, that actually can change the course of our genes. And there is a whole sector on this, which is epigenetics. So I think that is the greatest driver, but it highlights the importance of really doing more research in this particular field.
Thanks.
And I think we are at time, but thank you for starting this conversation, because as everybody mentioned, this is a part or the start of a journey, and hopefully much more progress, collaboration coming forward. And thank you so much for your time and generosity of your expertise. Thank you.